Hello and welcome. I'm Jennifer Black. I'm the New South Wales Mental Health Commissioner, and with me is Julie Dixon, our Director of System Reform. Today we're launching the What We Heard report, and that's the results of the consultation for the new mental health and wellbeing strategy for New South Wales, our biggest consultation in our history. But before we start, I'd like to acknowledge the traditional owners of the lands on which we meet. And for us, that's the Gadigal people of the Eora Nation. But I'm conscious that people will be dialing in from all parts of New South Wales. So I'd like to pay my respects to elders past and present and to any Aboriginal people with us here today. I'd also like to recognise those with lived experience and particularly thank those that contributed their wisdom to this work. And I recognise the bravery it can take to speak up for change in this sector. So today, a bit of a rundown on what we're going to be speaking about. I'm going to take us through the strategic landscape, so a bit of the background. Julie's going to talk about our consultation approach. I'm going to talk about the key insights, that is what we heard through the consultation, and then back to Julie to talk about the next steps in the development of the strategy. We will allow some time for questions at the end, and can I direct you to the Slido QR code at the side of the screen. You can scan that to submit your questions, or you can go to slido.com and enter the meeting code 1255021. Now we'll be doing questions at the end, and we may not get to all of the questions, but we will try and theme them and speak to some of the common questions. So let me start on the strategic landscape. So what's been the lead up to this work? The Commission started in 2022, and our first strategy was Living Well, and then midway Living Well in Focus. This strategy ended in 2024, but we have produced a final report which really reflected on what the progress had been against Living Well in Focus and what work is still to be done. So let me talk a bit about the new strategy. So the new mental health and wellbeing strategy will be a whole of government strategy. It will look at mental health, social and emotional wellbeing, and suicide prevention. It'll focus on mental health and wellbeing outcomes for everyone in New South Wales. And also it will have a targeted focus on care and support. The other piece of work that the Commission's currently doing is around suicide prevention. And whilst suicide prevention will be a feature of this strategy, there was new suicide prevention legislation enacted in late 2025. And the Commission is also responsible for that. So we will be developing alongside this 2 statewide whole-of-government suicide prevention plans. One of those an Aboriginal plan. We've also been required to set up 2 advisory councils, which have now been established and met. And we will also support government agencies to develop their local plans that align with the statewide suicide prevention plans. Let me talk a bit about the context for our strategy. It's not being done in isolation. We're considering a whole range of existing work. So that's other strategies that are important to this piece of work. For example, closing the gap and future health. We're looking at the national directions that are important to the work. We're looking at what other key government agencies are also doing and what are their strategies and plans that align with the issues that we're focusing on. So, for example, education, justice, communities. And I guess the important point is that this is not just a health issue. This is a whole of government issue. The next slide shows us our stakeholders. So this map shows the breadth of the stakeholders that the Commission works with in all of its work. And what I would say is that success really depends on understanding those different perspectives and genuine collaboration between those agencies and interested parties. So before we get into the consultation approach, I can tell you that we heard from lived experience, carers and kin, service providers, government departments, specialist population groups, and I'd like to thank everyone for their contribution. And I can reassure you that we read and considered absolutely everything that came to us. I'm going to hand over to Julie Dixon now to outline the consultation approach.
Thank you, Jennifer. And thank you to all of you online today that have contributed to the consultation process and to those of you joining today as well. As Jennifer said at the beginning, this, I think, has been the largest consultation undertaken by the Commission to date. And you've provided us with such important insights into what needs to change, but also incredible important ideas for how you think that change should happen. And so this information, through the What We Heard report and through the submissions, etc., will actually feed into shaping the next strategy. Overall, we consulted with over 5,500 individuals, and over 50% of those that participated had either lived or living experience. Mid last year, we partnered with the New South Wales Department of Customer Service to launch a Have Your Say public consultation platform. The survey was promoted through social media, through print advertising, and through multicultural radio. And individuals and organisations were invited to participate in completing a short survey and or providing a submission to us. In total, we invited around 500 organisations to participate in the consultation, and around 400 did in various different ways, either through completing the online survey or completing a submission or attending our roundtable discussions, or also by targeted consultations. So either Jennifer, myself or my team were also attending various forums, committees, meetings that currently exist. Any opportunity we had, we saw might be available to actually listen to those of you who are interested in meeting with us. Jennifer also visited communities across New South Wales, and we also held a range of one-to-one meetings with organisations and individuals as well. We also commissioned First Nations Co., an Aboriginal-owned company, to undertake consultations with Aboriginal communities and organisations. And throughout New South Wales, they conducted either in-person community workshops or virtual consultations, and other individuals and organisations could also complete a survey. Next slide, thank you. So in relation to the Have Your Say survey, 4,686 surveys were completed and over 170 submissions. Just in terms of a breakdown of demographics, around 60% of those of you that completed the survey indicated that they had lived or living experience of mental health challenges, psychological or suicidal distress. A significant proportion, as you can see on this slide, were living in regional, remote or rural New South Wales. Around a quarter of the respondents were from the mental health, wellbeing or suicide prevention sector. And around 22% indicated that they were born in a country other than Australia. Around 20% identified as having a disability. 10% indicated that they either currently had or had drug and alcohol issues. And 5% had either current or prior or previous contact with the justice or correction system. And finally, 4% indicated they were Aboriginal people. So our targeted consultations began with about 15 population groups. Either those groups had knowing a disproportionate impact on their mental health or unique mental health and wellbeing challenges as well. But as conversations progressed and more people came to us, it was really clear that we needed to continue consulting with other groups and communities, such as farmers, people with innate variations in sex characteristics, people impacted by harmful gambling, new and sole parents, and those affected by natural disasters and climate change. This consultation process not only highlighted the unique and experiences across New South Wales from different groups and communities, but importantly, the complex intersections between them all. We also heard from many people working in the mental health and suicide prevention systems, from government, departments and agencies, a whole range of non-government organisations, academia and professional colleagues. And your insights have really helped us understand what is working well, what needs to change, and the role that you think different parts of Commonwealth, state and local governments can play in improving communities' mental health and wellbeing. A key part of this work, as I indicated, was to consult with Aboriginal communities. And this is of critical importance because our work needs to be grounded in lived experience, cultural strengths, priorities and aspirations for Aboriginal peoples across New South Wales. Next slide. Thank you. It was also essential our consultation meaningfully engaged with people with lived and living experience, that is those with mental health challenges, psychological or suicidal distress, as well as carers, families, kinship groups, and importantly those that may have been bereaved by suicide. To support this, we partnered with various industry peak bodies and community organisations, as well as people with lived experience, to reach as many people as possible. As well as this, people with lived experience and caring are also directly involved in every level of the strategy's governance, including the Commission's Community Advisory Council, the Strategy Advisory Group that's shaping the strategy, and our Deputy Commissioners with lived experience. And finally, this isn't only just the broadest consultations undertaken by the Commission, but also one of the most comprehensive. We really think this is critical to ensure the strategy reflects your perspectives, your voices, across a diverse range of individuals, communities and organisations. I'm now going to hand back to Jennifer to talk about what we did here.
Thank you, Julie. So as Julie said, I'm going to take you through what we heard. And you'll see the breadth of that consultation. And it's quite a testament to the team that they listened to, read, considered everything that came through. What we've done though is we've themed this into 5 parts, if you like, of similar kind of issues. So I'll take you through them at a high level first, and then I'll go into a little bit more detail on each. So part A is system capacity and reform. And so that's things like the way things are structured, the policy environment, funding, workforce and governance. So how we're kind of overseeing all of this. Section 2, or Part B, is the mental health and suicide prevention service system. So that considers things like access to services, navigation, how easy they are to find, people's experiences of care, and there were lots of ideas about opportunities for improvement. Part C is mental health and wellbeing in communities. And so that really looks at things like prevention, early intervention, and the need for conditions or environments, if you like, that actively support people's wellbeing. And the need for solutions that go way beyond health. This is where whole of government comes into it. What can other government departments do in this space to actively support wellbeing? Part 4 is about different population groups. And so, as Julie has outlined, we heard from a whole range of different population groups. And we heard about how many of these groups are disproportionately impacted by mental health issues or suicide. And we heard a call for specific interventions for some of these groups. And the final section we've called recurrent cross-cutting themes, and that's really themes that kind of go across the board that are really important issues that we need to consider in the development of the strategy. And we recognise that in all of these parts there's a lot of interconnecting issues. So let me do a deeper dive into each of these sections. So part A, let's talk about organisational capacity, or what we've called organisational capacity. And so what we heard was that people were really asking for systemic reform. People wanted action. They felt there'd been many reports and reviews. They didn't want just another report about what was wrong with the system. We heard a lot about funding. We heard that we needed more funding, that we perhaps needed to change the way that we fund things or how funding is distributed. We heard a lot about needing longer funding cycles for a whole range of reasons. We also heard people asking for accountability and meaningful outcomes for the people who are accessing the services, not just measuring throughput. Many people acknowledge the good work of the staff that are already working in the system, and acknowledge that often they're quite stretched. So the next section in part A was workforce capacity and capability. What can I say? Workforce, workforce, workforce. We heard a lot about workforce. It's a challenge across the board. We heard also, though, that we needed to listen, learn from, and be led by lived experience. We heard about the multitude of challenges for rural and remote communities. Challenges around access, recruitment and retention in those regional areas, the isolation of remote communities. And we heard a fair bit about scope of practice. Do we have the right skills for the work that's out there? For contemporary practice. So part B is about the approach to and design of care and support. So we heard a lot of commentary about the approach and how services are designed and developed. We heard about a need for more community-based interventions, which goes alongside the early intervention, being able to access care early in distress. We had a lot of commentary on crisis responses. And from the survey, Have Your Say survey, the top 3 issues that people identified in this space were that they really wanted care to be close to home. They wanted it to be high quality and evidence-based. And they really wanted choice and different options in the care that was delivered. So if we go to the next slide. We heard that one size does not fit all. Lived experience told us that they really wanted to see respect and a rights-based approach to the delivery of mental health care. They wanted the care to really reflect their life experience, their own context. They wanted care to consider their culture. They wanted to be able to make more decisions, have more control and power in their own life as a result of our interventions. Services told us that social determinants were really important, that this is not just a health issue. They also spoke about continuity between sectors and that needs improvement, say between health, housing and justice, for example. We heard about the importance of physical health. And we probably all know that physical health is closely connected to our mental health. But we heard that the system doesn't always manage both of these well at the same time. We heard that people wanted care to consider them as the whole person and to look after their physical health needs as well as their mental health. We also heard a lot about trying to navigate the mental health and suicide prevention system. Finding the front door is quite difficult, and if you're new to wanting help around mental health, it's not really very clear where you can go. People spoke about meeting service ineligibility. So, for example, they heard that they were not well enough to access some of the services, or they didn't meet the criteria. And that's particularly challenging perhaps for people who have been to see a GP and perhaps then don't meet eligibility criteria for the mental health service system or the clinical end of the system. And we heard quite strongly from lived experience that people want a system that fits them, not one where the people need to fit into what the system offers. And we also heard a strong call for better support to navigate the system that can be really complex. So the next slide's about barriers to access. And we heard this consistently. Barriers could include things like the cost of services, long wait times, limited local services, which really limits your choice and finding something that's suitable for you. We heard about stigma and discrimination as barriers to help seeking. And we heard about the specific access challenges for identified population groups. In particular, I'll call out for Aboriginal people in rural and remote communities. And young people also talked about specific access issues for themselves. So still in Part B, prevention and early intervention. So we've kind of broken this down into 3 streams based on what we've heard. So the first is early intervention in life. So that's really a good start from childhood. A childhood that's free from harm. A childhood where you have access to the things that you need. And then we have early intervention in illness. And so that's really about early identification and not waiting until someone's in crisis before we dial in some support. We also heard about early intervention in episode and actually having services that really leave someone with the skills and resources to self-manage as much as possible. And access to early support when things aren't going well, and not just access to it, but it's easily accessible to people when they're first in distress. I'll move on to the third pillar that we identified, and that was mental health and wellbeing within communities. So people really wanted action to actively support their wellbeing. And that included things like how they live day to day, having connection and belonging to their communities, whether that be a physical community or potentially an online community. People need a purpose. And we also heard about some of the other social determinants. We heard about needing safe housing, needing access to education, employment, finance, freedom from harm and discrimination, and safety within our communities. And we heard a lot about connection to culture for Aboriginal people. So this slide just gives you a snapshot from the Have Your Say survey, where we asked people what was important for their mental health and wellbeing in community. And the top three were safe, secure and affordable housing, financial security, and freedom from violence, abuse and neglect. And it's probably worth a mention that a close fourth was social and community connections. So I want to talk a little bit about the findings from the consultation with Aboriginal communities. Julie's already spoken to you about the engagement with First Nations Co, who led those consultations for us. And this is really important because we know that Aboriginal people are disproportionately impacted by mental health and psychological distress. They have higher rates of suicide. So there were some key challenges that were identified in these consultations. And they were that mainstream models don't necessarily meet the needs of Aboriginal people. We heard about accessibility issues, and they might also be things like transport. How do you get to where the services are? We heard about a digital divide and people feeling digitally excluded, and that's really tricky if people live in rural and remote locations, and they might not even have the infrastructure to be able to get online if that's what's on offer. We heard about high costs. We heard about inflexible hours. And we heard about, we heard about the competitive procurement environment. And so if we want to allow more Aboriginal organisations into the care space, this was a real barrier to be able to go through those kind of complex competitive procurement processes. So we also heard about some opportunities here. The opportunity to co-design with Aboriginal people for Aboriginal people. And that reform should really be shaped by Aboriginal communities. There's an opportunity here to actually learn from Aboriginal people for us all around social and emotional wellbeing, culture and spiritual aspects that were important to the Aboriginal community. And we heard a lot about Aboriginal workforce, and that's at all levels. A call for Aboriginal clinicians and Aboriginal workers across the board in clinical and non-clinical settings. I'm going to quickly talk about Part D, which is the population groups, but perhaps without getting really specific about the needs of each. There are over 30 population groups that we spoke to and consulted with, and that was really to understand the unique context that exists for those population groups. And we often heard about the need for some specific tailored care that needs to be provided for those groups. We'll talk a bit more about where you can actually find all of that information on the specific groups a bit later. And finally, I just wanted to touch on the cross-cutting themes. So these were kind of issues broadly that we heard about that need to be thought about in all of the areas that we've outlined today. So complexity and mental health can be complex. People can have co-occurring experiences. And they particularly talk to us about how complex it is to navigate if you need to go to different services for different issues. We heard a lot about trauma and from different sources, trauma in early life, traumatic events, adapting after a natural disaster. We hear a lot about political and climate anxiety, particularly in young people. So that's another consideration for the strategy. And strongly what came through was prevention and a focus at all levels on how we're going to uplift in the prevention space. So before I hand over to Julie for the next steps, I really wanted to take you through the resources that accompany the What We Heard report. So, and these resources are all on our website. The full report is there. The report is over 200 pages long, so it's really comprehensive. There's a lot of information in that, but we've also created an executive summary and an easy read version of that executive summary. We have 32 detailed population profiles on the website, and you can go and read all of those. Julie mentioned that we had over 170 submissions, and for those who gave permission for us to share it, you can actually read those submissions on the website as well. And in addition to all of that, we are in the process of translating the executive summary into the 5 most commonly spoken languages in Australia. So that will land in the website soon. And this webinar will also be available on the website. Yes, on the website after today. So I'm going to hand over to Julie now to talk about what's next in terms of building the mental health and wellbeing strategy.
Thanks, Jennifer. So we put this slide together to show you the process going forward. But I just want to indicate again and stress the importance of the What We Heard report, which is such a significant piece for the foundations of this strategy. But there are many other aspects of other evidence as well. So you'll see here that the team are very busy looking at research evidence, evaluations from programs, initiatives, and obviously a focus around structural system reform as well. We're also looking at practice evidence, and we're conducting environmental scans both in other jurisdictions in Australia but overseas as well. And in addition to that, we're also in discussions with the government departments to find out what work they're doing already in the mental health and wellbeing space and what their priorities are. In terms of the governance, we established at the beginning of the process a mental health and wellbeing strategy advisory group. And that group comprises every government department. It also comprises the peak bodies such as Mental Health Carers New South Wales, Being, the Mental Health Coordinating Council, NADA, ACON, and Multicultural New South Wales. We've also have representation from Everymind and Black Dog, from primary health networks and local government. We think it's really important that we have a really broad representatives across different agencies and organisations to feed into this and help shape the strategy. As well as that, we have the Community Advisory Council that the Commission has established, as well as the Deputy Commissioners in Lived Experience. Over the next few months, we'll be building the strategy and drafting that. So we're aiming for a draft strategy towards the end of this year. In terms of our early thinking, we have 3 interconnected goals, which together work to improve mental health and wellbeing and reduce suicidal distress and lives lost to suicide. The first goal is to lead and mobilise reform across government. We know that creating lasting change requires strong, proactive, strong leadership and, as well, importantly, coordinated action across all levels of government. And we know that mental health and wellbeing are shaped by decisions made across all aspects of life, as Jennifer has mentioned, including housing, education, employment, justice, community services, etc. So the aim of this goal would be to focus on building the commitment, capability and accountability across government to drive reform. Some examples of what you told us we should be doing are to embed mental health and wellbeing into major considerations in major policies and decision making, and improving coordination between and amongst government departments and agencies so people don't have to continue to navigate disconnected systems. In terms of Goal 2, to promote and protect community wellbeing, this goal is really focused on creating the conditions to help communities, families, individuals thrive. It will emphasise, as Jennifer mentioned, prevention and early intervention and address the social, cultural, commercial and environmental factors that shape our mental health and wellbeing. And again, achieving this will require strong collaboration across governments, but also connecting with community services, service providers, including the private sector as well. And we know that we need sustained investment in prevention and community wellbeing. Examples of what we heard as ideas from you included further expanding community programs to support children and young people, so support's available before they experience a crisis, strengthening community connections and reducing social isolation, and addressing, importantly, housing insecurity, financial stress, and discrimination, which can all negatively impact on our mental health and wellbeing. And finally, the third goal is to transform care and support. This goal will focus on access to person-led, trauma-informed and relational care, and support, importantly, as well for carers and families. It aims to strengthen the system to improve experiences and outcomes and ensure additional support is there when we need it the most. Throughout the consultation, we heard a strong call for a genuine non-wrong door approach where people can access support wherever they first seek help. We also heard the importance of ensuring that care is grounded in a human rights framework and responds to the individual's needs and circumstances. Some examples of what you told us were to make it easier to move between services without having to repeatedly tell your story multiple times, expanding access to community-based care and support close to where people live, as well as improving coordination across mental health, drug and alcohol, housing and social supports. And while this strategy will set a long-term direction, it must continue to evolve. New evidence, emerging challenges and insights from people with lived experience, from practitioners as well as researchers will help shape implementation over time. And although these goals group related areas of work, they are deeply connected. Success will depend on working across the traditional boundaries and ensuring efforts are focused on coordination, integration to deliver better outcomes for all the people of New South Wales. So that's, I think, the talking between Jennifer and I, and now we want to hear from you. As Jennifer said at the beginning, just a reminder to scan the QR code on the screen or go to theslido.com and enter the meeting code 1255021. Your questions will appear on the screen in front of us, so we can go through some of them. Thank you for listening.
Great, thanks Julie. We've got a couple of questions already, but please send some more to us through the Slido QR code. The first question is, how is lived experience going to continue to inform the strategy? Well, we've heard quite a lot so far from lived experience. We know that over half of the people that have contributed have a lived experience, but the Commission has a range of touch points that I can talk you through. So we have a strategy advisory group, and that has every government department in it, but it also has the peak bodies. So Being is there, the peak body for lived experience, and mental health carers are also there at that group. In addition to that, we have a community advisory council that advises the Commission on its work, and there is a broad representation of lived experience at that committee. We also have internal staff with a lived experience and 2 deputy commissioners who are heavily involved in the development of the strategy. And if needed, we can go and seek advice through our networks and peak bodies. Is there anything you'd add to that,
No.
Julie?
Nope. That's good, thank you.
And of course, I knew someone was going to ask this. Who's going to fund all this work? Good question. But, you know, it's our expectation that we're developing the strategy that decisions should be made in line with that strategy. The other thing I would say is that this is not just a health issue. And so we've got every government department at the table working with us on this. So the responsibility sits across government for this. So it's not just one department funding it all. You know, beyond developing the strategy, there'll be an implementation phase where we'll be working with those government departments on what success looks like. Any of these questions you'd like to answer, Julie?
I think the one about getting caught between various strategies across state and federal government and how bringing it together, it's such a complex landscape. But that said, we know that there's a renewal of the National Mental Health and Suicide Prevention Agreement, and I know that there's a process for consultations on this next agreement. The Commission's been invited to participate in that consultation process, but actually, importantly, we've actually gone back to them and said, what about the What We Heard report and all the information that we've just gathered from the consultation process? And as Jennifer mentioned, going back over and over things, you know, we have so much rich information here in this report, and so they've made a commitment to review what's been heard and to be able to have this What We Heard report and the various documents such as the submissions actually shape the next agreement as well. But it is a complex space, and Jennifer is now co-chairing the New South Wales Mental Health Task Force, where there are discussions around that interface between the various levels of government. I guess the other thing to say from my perspective is we have local government at our strategy advisory group, and I find that often local government can sit to the side, but they provide such a valuable source of services, particularly around community development, around empowering communities to be more in control of their mental health and wellbeing. And so for us, it's about bringing local government on this journey as well, because they have such a critical role to play. Yeah.
So the next question is, what's different about this strategy and how can you ensure it will actually happen? I think there's a couple of things that I would say. So the mental health and wellbeing strategy will be an overarching whole of government strategy, but I think the if we put that with the suicide prevention legislation, there's some things in that legislation that will actually require government departments to actually start to develop local plans. So they'll actually be responsible for some actions, and we can leverage that for both the mental health and wellbeing strategy and the suicide prevention plans. I think the other thing that I would say is that we have every government department at the table willingly. So they're there because they understand that they have a role to play here. And, we will work with them throughout the implementation phase and provide as much assistance as we can to them to actually help them get their initiatives off the ground. Is there anything you'd add to that, Julie?
No, I think it's about making sure the governance is a robust governance in place to ensure that there's a focused effort around the priorities identified in that strategy, and a good monitoring and reporting on progress and barriers. And some of you might be aware that we're also developing a mental health and wellbeing outcomes framework as well. So that's kicked off, and the work's being guided by an expert reference group with both national, international and state representatives on that group as well.
Cool. Do you want to tackle the multiple profiles one? Do you want me to read
so
that
somebody's
out?
put, how do the population profiles include people with multiple profiles? So I guess what we heard really clearly, I mean, we know, I don't think many of us sit in the only one profile, but what we did hear very loud and clearly was that people did want to, those that had connected with a particular population group did want to be heard, but of course, none of us are simple. Nobody's very simple. Every human being bring their own complexities and their own experiences and context. So I guess we need to design a system that basically allows anybody, as I said, and we heard very clearly, that there should be no wrong door, and a system that should be accessible to those to get the right care and support. We did hear that again, time and time, that the care needed to be tailored, and it needed to be holistic as well, and it needed to be person-led. So I think building a strategy that is trauma-informed, person-led and relational, and has continuity as well for people that have enduring mental health challenges of critical importance to improve outcomes as well.
Okay. How does this strategy ensure what is already working well will continue to be funded? Well, I guess we don't control the funding, but we would be, what we heard from people was that they wanted high quality evidence-based care. So there would be no reason not to continue with that care. And I guess that's something for us to think about how we write that into the strategy, about supporting what's working well rather than stopping anything. I think it's kind of challenging, isn't it? Because sometimes we get money for a year to start a pilot program. It's not really enough time to do that kind of evaluation to actually see how it's making a difference. And so I think that's one of the tricky elements of this, isn't it? That we need kind of continuity of funding to actually really show the long-term impacts of programs. So the next question is, you have spoken about government at all levels. Who is the audience of this strategy? The strategy will be branded in the government branding because we want government to own this strategy. One of the challenges about Living Well in Focus is that people very much saw it as a commission strategy rather than a strategy that the government owned. So I think that's what's really encouraging to us about how willingly government departments have come to be part of the conversation. isn't it? That that they will be responsible. So we would like to write the strategy in a way that puts them, gives the responsibility to them to enact the strategy. Anything you'd add, Julie?
No, I think, bringing as we are government departments as well as agencies on this journey is of critical importance. And many government departments are doing a lot of work in this space. And some of it's about recognising what they're doing and others knowing, but it's also about interconnecting across as well and leveraging off the work being done across government agencies. But we know there are gaps, and so that focus has to be, our focus of our strategy needs to be on what needs to be strengthened or what needs to be different as well.
Workplaces can have both a risk and a protective effect on individual mental health. How will the strategy link to efforts to improve workplaces? Yeah, good question. And probably when I talked about workforce, I didn't touch on this, but it's actually certainly something that we've heard. Workplace wellbeing is a huge issue and one that will be considered as part of how do we, particularly, we've got a frontline workforce. How do we actually make those workplaces safe? How do we support staff in those roles? We've heard a lot about burnout throughout the consultation process, so it will definitely be there. Anything you'd add, Julie, to that?
No, but again, just to stress that safe work and eye care, etc., we've been consulting with as well to find out the challenges from different workforces, and we're continuing to engage, particularly around the work we're going to be doing in suicide prevention to build a statewide suicide prevention plan as well. So it's a bit of a focus for us going forward as well.
And we have Safe Work on our strategy advisory group as well.
Yeah, that's right.
Not sure I understand the next question. So we'll go to the other one while we think about that. Can you read that, Julie?
No, I just think, so there's a question, will you be employing a specific workforce? So the Commission has a budget and that hasn't changed. So I guess to say that when people resign, we always look at what kind of skill sets do we need in the teams across the Commission to try and make sure that we have the right capability internally where possible. So, but we don't have a specific workforce as such. The team that I manage do have different skill sets to help do the work as well.
Can you read that out?
So Youth Justice says 90% of youth in detention. Will the strategy provide for early intervention, peer support as detention alternatives? Further, can multiple use of Callan Park and Roselle be opened up to community supports to offer activities? So we've been consulting with people who are currently in the justice and corrections system and those that have previously been in contact. And so this has to be a very an important focus for us around early intervention and peer support. I do know that in the previous Living Well in Focus strategic plan that the Commission developed for whole of government, it did lead to an expansion of various justice programs, expansion of court diversion, etc. as well. And so that's, very important priority population group. We only just finished consulting a month ago with people currently in the corrections system as well. In terms of Callan Park, that's dear to my heart because I go there regularly and love to walk across there. I guess that's out of the remit of the Commission around that. And I believe there's a new plan being developed by New South Wales Government, although I'm not up to date, but I understand there is a plan underway there.
And the only other question we've got is, when will the strategy be released? Our work will be done on the strategy at the end of this year, 2026. It will have to go through the task force and cabinet.
Yep.
So we probably can't give a specific date on that, but we'll be trying to process that through those avenues as soon as we've completed the strategy.
Yeah. And sitting behind that will be some sort of implementation plan as well with whole of government.
Yes.
So that will involve many discussions.
Many discussions.
with government departments and et cetera as well. Yeah. Last one.
Yeah, so can I continue to provide feedback to the strategy? As I outlined before, we have a range of avenues that we use to perhaps test ideas and elements of the strategy, which we'll continue to do. The strategy itself will probably not go out for another kind of consultation approach. The time frame probably doesn't really allow for that, but we certainly will go and seek feedback on particular issues where we feel we need to, or where we feel that perhaps things aren't resonating in our current networks. So that looks like the end of our questions. Can I just thank everyone today for coming along? Thank everyone who contributed to the What We Heard report, and have a great afternoon. Thank you.